Good morning, everyone. This session will be a snapshot of the palliative care across the OVOHT. I'll get us started with our land acknowledgement. The Ottawa Valley, Ontario Health Team acknowledges it's located upon the traditional and unceded territory of the Algonquin people and respects the traditional knowledge and healing developed over generations. We have the privilege and responsibility to serve First Nation, Métis, and Inuit of many backgrounds and from many treaty and non-treaty lands and territories, and to demonstrate respect for the contributions and cultures of Indigenous peoples. Now, I'll stop sharing my screen and pass it over to Amanda to give us an overview of the palliative care data.
Hi, everybody. My name is Amanda Burcher. I'm a nurse practitioner and I work on a team called the Regional Palliative Consult Team. You're probably familiar with my colleague, Erin McCabe, who is the consultant in your area, supporting primary care team members who want to provide palliative care as part of the care that they give. And I work 1 day a week as a non-physician palliative care clinical co-lead, and I report to Ontario Health as part of that work. So I'm here today to share with you a deep dive we took into the Ottawa Valley OHT data around palliative care. And really the heavy lifting was done by Brian Sinark, who unfortunately has left his position, so can't be with us today to join this presentation. But he really did all the heavy lifting for the data, and my role was around sort of bringing it some meaning and some context. So today we're going to just review and contextualize that data, and then I'm hoping to have some time to get your feedback and your thoughts on what might be driving this data and some potential solutions. That's just an outline of the day. We'll skip that. So just for context, I sit on, I think there's a few members actually here today from this committee as well, but I sit on the Renfrew County Palliative Care Network, and their mandate really, item number 2 under network objective, they really want to use sort of performance data to drive and improve access to quality palliative care across the continuum of life. And so as part of this mandate, Ontario Health is collecting data around palliative performance and home care visits and whatnot. So this all started when we looked at some of that Ontario Health data, and then people had questions and they wanted to sort of go from a Champlain-wide view of the data and really dig down at what's happening in Renfrew County. And that's what Brian was able to do. He was able to look at things, zoom in a little bit, on our data. So first section is on deaths and location of death. This is just kind of setting the context. So death can fluctuate. This chart shows that deaths can fluctuate quite considerably. However, we have a little bit of a boost in deaths in December and January, and a little bit of a decline in dying over the summer in July and August. And then the 3 different colors there are just the different years, and you can see how it fluctuates month by month. This shows death by age group. So not unexpectedly, the group aged 85 plus are the biggest population who die in Renfrew County. And then it declines kind of as we go down in age. This next slide looks at comparing Renfrew to Ontario at the top in the green. Renfrew is red, and all of the other sort of districts or census divisions are outlined. And where do we sit with our population that are aged 65 plus? So in Renfrew County, compared with Ontario, we have a higher proportion of people who are over 65, and that's expected to increase significantly in the coming 4 years. And that's just compared with all across Ontario. There's other regions as well that have a high proportion of over 65, but we're certainly in the top third. This next slide talks about, based on our consensus and where we're going with the numbers of people over 65, what are we going to need in our population? And so we're expected to see a 45% increase in the number of deaths in the region, with access to palliative care, of course, being incredibly important as this population ages. So next, we're going to talk a little bit about what's going on presently in terms of home care and identifying patients who need a palliative approach to care. So this slide compares the Ottawa Valley OHT to Ontario and the other Champlain region OHTs. in terms of people, how many people received home care in their last 90 days of their life. And so the Ontario standard, or the Ontario presently across Ontario, about 20.3% have received palliative care. But you'll see that even Ontario-wide, we're below the goal. The provincial goal is 35%, and even Ontario-wide, we're below the goal. The Ottawa Valley OHT is a little bit below the Ontario standard, with 17.3% of people getting palliative home care in the last 90 days of their life. And then the sort of line graph on the right is just showing the trend over time. We're sort of holding steady, I would say, around 17 to 18% of people who have died who received a palliative care home care visit within 90 days of the end of their life. This next slide is comparing nursing and PSW. So when we look on the left graph, Ottawa Valley is doing pretty well compared to Ontario. We're in terms of number of nursing visits within the last 90 days of life, we're actually higher than the provincial average. But unfortunately, on the right, we're quite a lot lower. And I see lots of heads nodding. People aren't surprised, when they see this. So access to a PSW or homemaking supports, we're below the provincial average and below a number of other OHTs. And that wasn't surprising to the people at the Renfrew County End of Life Network either, in that it's well known in the area that get access to PSWs is a bit of a challenge. This slide, again, looks at case management visits. So the coordinators from Ontario Health at Home, and we're above average compared with Ontario for how many case managers are able to get out and assess patients in the home within 90 days of the end of their life. And then on the right is our allied health. So how are we doing with access to social work, occupational therapy, physiotherapy? And these are just the number of visits that occurred from these different disciplines within 90 days of end of life. So people are getting visits from social work, occupational therapy, and physiotherapy, and we're quite close to the provincial average for that one. This next section talks about family physician or visits. It doesn't talk about nurse practitioners. I know there are some nurse practitioners working in Renfrew County, but they don't typically bill OHIP. So this next section was really looking at OHIP billing data for GP family physician visits. So what does this slide say? So this slide basically looks at heavy palliative care users, which is the low purple bars on the right, compared with light palliative care users on the left. So the number of family physicians or GPs who billed for one palliative home patient from our healthcare unit, and those are the numbers. And the shades of purple are across the years. So 2023, 2024 is the darkest color of purple. So there were 72 different GPs in Renfrew County who billed for one or more palliative care visit. The next in the middle is how many patients billed 6 or more palliative care visits per year. And you can see it starts to go down, but it's sort of staying steady over time. And then the third one are what we would call very active physicians. So they bill from 20 or more palliative patients per year. And actually that's going up over time, which is a good thing, I think. But last year, or 2023, 2024, 15 physicians in the county billed for 20 or more palliative care visits. And then this just breaks that same information down, but by geography. So we wanted to look at the different kind of geographic regions within Renfrew County and how is their access to physician support. So we can see, for example, in Pembroke and Petawawa, that the GPs that billed for in the middle for 6 to 19 palliative patients, there were 2, and there were 3 who billed for 20 or more. Compare that with, say, Deep River, and GPs who billed for 6 to 19, there were 4. GPs who billed for 20 plus, it seems like there's only 1 in the area who's doing sort of high volume of palliative care visits. And I will share these slides for distribution after if people want to have a closer look, because I do recognize we're going through this fairly quickly. This next slide speaks to physician home visits in the last 90 days of life, comparing us with other OHTs and with the province. And we're actually higher than the province. So we're doing better in terms of physicians willing to do home visits. However, province-wide, we're not meeting the benchmark. So the provincial benchmark or goal is 35%, and we're province-wide, we're below that. And then again, on the right, it just shows a year-by-year breakdown of those visits. And I would say we're holding our own, 24 to 29, 30% per year. This next area, repeat emergency department visits, I would say is an area that Ontario Health is focusing on as part of their palliative care improvement plan over the next coming years. So looking to reduce unplanned emergency department visits in palliative care patients. So this is just kind of an informational slide the green is within 90 days of the end of life. The red is within 30 days of end of life. And then across the bottom is the number of emergency visits. So not surprisingly, it goes down as we move across. But quite a significant proportion of palliative patients are having 2 or more emergency visits. And in fact, quite a few are even having 3 or more, especially when we look at 90 days ahead of the end of someone's life. Then we were curious, is there a difference with gender? So there is actually a bit of a difference. So men seem to use the emergency department more than women. And that's true across all age groups, but certainly we see that more as we age, the difference. So not sure what that means, but just that men are bigger users of the emergency department. This next piece was really surprising to me when Brian shared this data with me, but this is looking at emergency department usage based on deprivation score. So the deprivation score is kind of your socioeconomic status, your access to resources and whatnot. And the lighter color means you're the least deprived, and the darker color means you're the most deprived. And so interestingly, the people who were the most deprived were the least likely to use emergency departments. So that was kind of interesting to me, the data there. And then again, this looks at repeat ED utilization across geographies. So, our lowest in the county would be Arnprior Braeside, 12.4%. Our highest in the county would be in the Barry's Bay area, 18.6%. And I know some people at the network had thoughts and kind of understandings of their local context that contributed to this data. So that might be something important to discuss when I'm finished here. I only have like 3 more slides. This next section looks at hospital admissions. So this is people who had 2 or more unplanned hospital admissions in the last 90 days of their life. And Ottawa Valley is quite significantly higher than the Ontario average and the rest of the OHTs in our region. And that number actually seems to be climbing. We were quite low 2022, and we've been steadily increasing since. So not sure why that might be, but it seems to be there's a heavier rate of hospital admission for our palliative care patients. And just a reminder that this is 2 or more hospital admissions, because we recognize that some people might choose to be admitted to their local hospital for end-of-life care, and that's their preference. So we really wanted to make sure that those people were not captured by this data, which is why we chose to use 2 or more. So this is a little summary prepared by Brian, and you can think of the green as stuff we're doing well in the county and the red as stuff we could improve on. And I do apologize, I couldn't find, he had a slide around long-term care, palliative care, long-term care hospitalization, and that slide did show that people tend to stay in their long-term care home to die. They don't tend to have high hospitalization rates, so we're doing well in the county for that. Where we could improve would be PSWs, of course, repeat hospitalizations, and then there's some areas where rate of death in hospice is low. Deep River, it was low, but of course we know that there's some beds coming. The proportion with end-of-life home care in Deep River was also low. We looked at GP palliative billing by region, and in Pembroke, Petawawa, an area it's lower compared to the rest of the county. And then we looked at repeat ED visits, and in Deep River and area, as we talked about, it's a little bit higher than in the rest of the county. So what's the next steps for the Renfrew County Palliative Care Network? I don't think anything has been settled on in terms of a concrete plan, but they want to look a little deeper into how we could maybe get these PSW rates up a little higher in the county, address some of the inequities across geographies. I know Erin has been working closely with a physician colleague of ours to do some education for family physicians to make sure that they are billing for their palliative visits and getting remunerated appropriately for the work that they do as part of, encouraging them to take on palliative care as part of their roles. And then looking at how we can address these high ED utilization rates in the county. So that's it for me. I'll leave my slides up in case anyone has any slides they want to go back to. But do we have time, Emma, for questions?
Yes, I think absolutely, Amanda. We can take questions now. We can also, at the end of the session, take collector questions for both you and Judy. So happy to save some time here for any questions. Moira, thank you.
Thank you. I'm not sure how to frame the question, but I'll just put it out there and you can sort it out maybe. I'm wondering if there's a correlation with seniors who are unattached to a GP, that I'm thinking of men who might not be attached. And so when they are approaching end of life, they're ending up in emergency to get some support. I'm just thinking there might be some kind of story there that should be looked at. Does that make sense?
It does to me, Moira. I'm making notes. I think it's worth looking into.
Mm-hmm. I have one other thought too, and then I'll mute myself. It was regarding the prevention side, that sometimes as a senior, and I am a senior, that you just plod along and you think, well, that's just part of aging. And yet, again, it might be part of being unattached, or more recently, I think GPs have had to focus on one area when you go to see them, instead of looking at the whole person and not looking at the prevention side and linking with the allied health as well. Like, it's a bigger story. And so that maybe you wouldn't have, if you got the right engagement strategies, you may not have moved into palliative care as soon as you did. It's a thought.
Isn't that just a reflection on our current situation? Hey, Moira? Yeah.
Seeing reactions there too, agreeing with you, Moira. Thank you so much for both of those. I know we might have some more discussion and questions at the end for both you, Amanda, and Judy. If there are no more at this time for Amanda, maybe we'll go on to Judy's presentation, an example of an approach to care, and then we'll have a collective discussion at the end with possibly some more questions. Thank you so much for that, Amanda.
My pleasure. And like I mentioned, I will send this slide deck to, I guess, Emma, do you want it, or?
Sure, yes, you can send
Emma?
it to me, and either one of us will be absolutely fine, Amanda. We'll make sure it gets out.
Perfect. So I'll circulate these slides, and people are welcome to have a deeper look at them. Thanks.
Thank you so much, Amanda. And now over to Judy.
Good morning, everyone. We're going to talk about the birth of a palliative care program at the Petawawa Centennial Family Health Center this morning. Next slide, please. And the what. So we identified a need to enhance education, training, resources, and workflows. We didn't have a standardized framework across Renfrew County. The goal is to increase confidence and competence of our team in providing compassionate, community-based palliative care, and to implement a consistent and high-quality approach with scale and spread across Renfrew County. We're hoping that the team will be able to proactively manage serious illness as opposed to reactively responding to crises as they arise. This should assist in decreasing burnout, decreasing ER visits, building system capacity, and improving coordination by enabling early intervention. Next slide, please. The why. So the story starts with my dad. He had diabetes diagnosed at 42 years of age, and we all know diabetes is a circulation disease. My mom, who is a better dietitian than I am, although not registered, we sometimes called her the food Nazi, but she was able to follow his meal plan along for the 50 odd years that he had diabetes. My dad had an MI at 88, followed by open heart, retinopathy, neuropathy, frailty, and palliative care was refused at their home, even though the services were offered. And I do believe it was because they both associated palliative care with imminent death. Clinicians are afraid of the burnout with the heavy lifting of complex cases. Enter stage left, Erin McCabe and the RCPT. We're looking at the concept of death, the comfort level of this concept. We're looking at facilitating people obtaining care closer to home, expanding the community paramedicine inclusion visits. 2% of patients die each year, leading to approximately 160 to 200 PCFHC patients that could be obtaining benefit of palliative care. Next slide, please. So the who is next. The Quality Improvement Palliative Care Team was established. Erin McCabe from RCPT, as you are aware, is the team lead. I'm the executive sponsor. Lisa Hawkins is the evaluation data measurement specialist. Doctors Katie Forfar and Jonathan Fitzsimon are the medical leads. Christy Hills-Walton is a patient partner, and Kaylee Keel is the EMS community partner. We've had hands-on participation by the OVOHT with encouragement. We've had involvement of the primary care network in the OVOHT. We have strong support by the PCFHC Board of Directors. So all of the staff at the PCFHC, and we're going back to July, and we even involved one physician who just started actually as a signatory on November the 1st. Next slide, please. The how. So we had interviews, and this was done by Erin with admin, docs, NPs to assess palliative care knowledge and comfort level. And we do need to keep in mind that a number of our docs are in the integrated virtual care program, and their level of comfort in dealing with palliative care was not the same as an on-site doc. So that's really was the impetus for getting this program up and running. We applied for the Healthcare Excellence of Canada Right Care Challenge. One of our NPs, Kirsty O'Brien, accessed online death certificate training. We tweaked really an early palliative care identification tool as an e-form in our EMR, Oscar. And we participated in a webinar offered by Grey Bruce, OHT, on remote care monitoring. This cast the net further afield and included community paramedics in the concept. So we did pull a list of palliative care patients from Oscar, and these patients may benefit from a palliative approach to care: COPD, CHF, end-stage kidney and liver disease, malignant disease, advanced dementia. These were pulled using ICD-9 codes from our EMR Oscar. The system navigator shortlisted and reviewed the charts of these patients for accuracy. Next slide, please. The how with respect to education. So palliative care specialist, Dr. Jessica Roy and Erin, presented on a community-based palliative care program for all PCFHC staff in 2025. We made this mandatory, and we YouTubed it. I don't know if that's a phrase, but we put it on YouTube so that people who were not able to attend could go back and watch it afterwards. We brought it forward as a concept to the primary care network for distribution to other clinicians in the area as well to participate should they be desiring to do so. Next is Drs. Sane Sao and Sammy Winemaker, well known for their Waiting Room Revolution webinars in the past. And the Renfrew County Palliative Care team is going to bring them forward in January for 2 more webinars, and followed by their new book. Hospice Renfrew and Madawaska Valley Hospice are going to provide an in-service on hospice care in the winter of 2026. I can't believe I'm saying 2026. Holy cow. Leap course, a mini leap course was offered in the fall of 2025, and a number of my staff attended to refresh their knowledge of palliative care. We have an in-house palliative care session planned for February of 2026, and Erin's leading this, How to Have Difficult Conversations. Next slide, please. And so it continues with the how and education. Erin as the team lead and Elaine Burns as our system navigator are going to do a palliative care tour to meet Ontario Health at Home staff, to meet the care coordinators, to meet the discharge planners, to meet the entire team in Renfrew County, to meet community paramedics, to develop that relationship, to attend palliative care rounds with hospital and community partners to further develop those relationships. And it's not off the radar to do a possible tour with the Gray Bruce system navigator to see hands-on how it's done. Next slide, please. The how logistics. An approved, validated survey from Healthcare Excellence Canada was conducted. A formal e-referral process is being formulated with Queensway Carleton Hospital. And what's interesting about this is that the OHT has requested that Petawawa Centennial be the entry point for e-referrals for unattached palliative patients. And we will find them it's really to track numbers, but we will find them a place closer to their home to access care. The Right Care Challenge was approved by Healthcare Excellence Canada. We then made a submission to Ontario Health for remote care monitoring, which was subsequently approved. We now have biweekly meetings with Gray Bruce to work through their implementation guide. And we actually find that very logical way of introducing a program to our area. We're also learning about Cloud DX. That's the platform that we intend on using. And we are mapping the QI journey based on the Gray Bruce's implementation guide, but using Renfrew County's, we're always a little different in Renfrew County, so we're making it ours. Next slide, please. The finale, or maybe not. So the TPA for remote care monitoring is for 25-26. And as you know, we have about 4 months left in this fiscal year. So our outcome measures are 10 patients to be remotely monitored. But we have gone ahead and hired a systems navigator, and she has a particular palliative care skill set. We anticipate going live with Cloud DX early to mid-December. The second round of provider surveys to assess knowledge transfer and comfort level of our providers will happen in March of 2026. And an expansion grant submission made for 10 additional remote care monitorings with other fits has happened. I just placed it on the 14th of November, so we'll see what transpires with that. So it's anticipated that this project will scale and spread across Renfrew County. And one of the things that I strongly believe in is starting small and then making it grow.
So once again, thank you so much to Judy and Amanda for this wonderful presentation. And thank you to everyone for joining and for the great discussion and questions. We'll be sure to be sharing this in the follow-up to this session. Thank you all so much, and wishing you a good Friday and weekend.